So I think that's a good critical mass. So maybe we'll start with introductions. Good morning, everyone. As we were just saying, I know it's been a hot couple of days. I think the temperature is going to be more seasonal. And thanks everyone for joining this morning for what is the last pediatric grand rounds of this academic year before we take a little bit of a hiatus over the summer. It's a great grand rounds to end on as we have a presentation around Precision Child and Youth Mental Health, the PCYMH Collaboratory by Kathy Pajer and Christina Honeywell. I'm going to begin with the land acknowledgement. Ottawa was built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And we are still in June, and June is Indigenous Heritage Month. So I would ask everyone to take a moment to reflect on the land acknowledgement and the lands that we're privileged to work, live, and play upon. So I'll give a bit of an introduction for Kathy and Christina, and I'm a huge fan of both of them and the leadership they've shown in the PCYMH Collaboratory. Kathy Pajer is a professor of psychiatry at the University of Ottawa and formerly served as the chair of Department of Psychiatry at the University of Ottawa and was chief of psychiatry at CHEO. She currently serves as the director of the PCYMH Collaboratory, which has been supported by a generous philanthropic donation in partnership with SickKids. She is also the clinical and scientific director of Project Echo Ontario, Child and Youth Mental Health. Dr. Pajer has spent much of her career in the US as a clinician scientist, focusing on stress response system in adolescent girls with behavioral disturbances, and has been in Canada since 2011, first at Dalhousie in Halifax, and then in 2014 moved here to Ottawa and has taken many leadership roles clinically, research, and education, and has received numerous awards recognizing her contributions, including the 2024 CHEO Research Institute's Osmond Impact Award. Christina Honeywell is the operations director at the PCYMH Collaboratory. Christina has held a number of roles. She's a genetic counselor by training and was the professional practice lead for genetic counselors at CHEO. She completed the CHEO Works Fellowship, earning her Lean Green Belt, and has worked in a number of quality improvement projects. And prior to joining PCYMH, was the CHEO Foundation Stakeholder Liaison, in which she, in that role, she helped develop strategic partnerships between the Research Institute, the hospital, and the foundation. The title of their presentation today, Can Pediatric Mental Health Care Be Personalized? Advancing Child and Youth Precision Mental Health Framework. Over to you, Kathy and Christina.
Thank you so much, and thank you for that lovely introduction. Welcome everyone on this slightly less heat-driven day. We're supposed to be a little bit better. Glad you could all attend, and without further ado, we'll move on. Okay, so what is precision mental health? Now, in the case of kids, it's helping kids with mental health problems get better faster by not just treating their symptoms, but instead developing precise treatment plans tailored for them based on knowledge about their body and brain function, lifestyle, and environment. So that's the definition we're working with. Now, what's the problem we're trying to solve? Here you have 10 kids, okay, who show up to the clinic, let's say at CHEO, good place, and they all can have symptoms of depression. They all receive the best care that we have to offer. What's the problem? When we come to the end of care, 5 of them, or 50%, will not be better. That is, our treatment guidelines for care, even if they're followed absolutely, wind up with 50% of the kids. That's for depression, but the other disorders are almost as high as that. Our treatments don't work for everyone. Is that just with kids? Because it's important you see the bigger horizon. Unfortunately, it's not. This is from a 2022 huge umbrella review, and this is the response rates for both pharmacotherapy and psychotherapy together and separately, encompassing over almost 4,000 RCTs and over 600,000 patients and all major mental health disorders. The majority of effect sizes for target symptoms getting better in both types of modality or a combination were all in the small range, 0.11 to 0.32. And these are effect sizes coming from meta-analyses. That is really dispiriting. And the authors conclude that a paradigm shift in research seems to be required to receive any further progress. So here are our clinical practice guidelines. What is going wrong, right? I don't know. What is going wrong? This is what we walk around and ask ourselves. This is what evidence-based care has led us to. But even when we follow it, they don't get better. Well, one of the things that we're thinking now is that we don't know enough about patients, and that one size fits all is not good enough for all patients. So one of the things that we're trying to do with Precision Child and Youth Mental Health is we're trying to get to know the patient better, as in the definition, collecting data about their bodies, their lifestyle, their environment, to see if there are subgroups in research along those profiles that respond differently to treatment, and then apply those to the clinical setting so that somebody like me as a clinician can say, aha, you have this profile, maybe we should start or work with this. Okay, so don't we do that already? We get asked that all the time. Don't you already tailor treatment? Yes, we do tailor treatment. All of us do. The trouble is that we can't tailor treatment very well. Well, why not? Well, let me give you a little example. So if we're going to talk about a pediatric oncological disorder, let's take a look at pediatric lymphoma. All right, here's the workup. It doesn't matter to me that you look at every single thing that is there, every single test to be ordered. What matters is note the number of categories of things that we can order to profile or understand a kid, 10 of them. This is what we have for, let's say, pediatric depression. We can collect information on the symptoms, we can collect mental status, age, sex, and gender, and maybe family history is relevant. You see the problem? However, now with the convergence of new technology, AI, social media, the internet, here is what is the potential for being able to develop precision mental care. All of the gray ovals in the outline, the perimeter of the graphic, are potential sources of information for our patients to help us understand and deliver precision psychiatry. Things are radically different. This has led to a very recently published precision psychiatry roadmap. It's for adults, but it has really quite a bit of value for children. The only thing, as all of us dealing with the pediatric age group know, is that the thing that's in the background of children and youth is that ever-changing development, right? And when you have roadmaps like that don't pertain to pediatrics, it doesn't take that into account. Be that as it may, at the top part of the diagram, you see what we're fond of kind of calling the Harry Potter sorting hat. You know, the kids came, they put the hat on, and it told them what house they belonged to. It's the same thing with precision. We're trying to sort the people, the patients, into groups based on specific treatment responses, predicted treatment responses, prognosis, etc. In the green, you have the domains, and you see number one is symptoms. Number two is behavior. We've got cognition, but now we're getting into some things that are new: cognition, brain integrity and activity, cellular activity, environment. And the technologies are really what's allowing us, you see every one of those go up into the green. And so we've got digital, cognitive tasks, neuroimaging, omics, and the exposome. So what does this precision roadmap mean for our work? So I'm going to ask you, these are a bunch of questions, and tell you the answers of things that frame the paradigm because of the roadmap. What research questions should we be asking now for precision child and youth mental health? What are valid biomarkers and non-biological markers of symptoms, of treatment reactions, of prognosis, or, and I don't want you to forget this, precision population level to prevention interventions? Because population mental health, if we forget that in precision mental health, it's going to never get off the ground. What new treatments can we discover from the above? If this is a biomarker of treatment response, could it actually mean that it's an etiologic factor? What profiles, putting these things together, of biological, lifestyle, environmental features are associated with above? And can we predict the future of the course? Can we predict the future of service utilization outcomes or administrative healthcare issues like staffing complement and costs? These are all very important for patient care. And can we implement precision mental health in the clinic, the community, or in prevention programs? Can we actually do it? So those are the type of research questions. What are the main methods? Using big data, for example, from harmonized integration of multiple research data sets, EHR records, population data, social media data, with artificial intelligence. And then we can study many of those things that you saw on the roadmap: omics, lifestyle factor, environmental, etc. What are the main methods? Integration of this research with preventive and population medicine is a very important method to work on. And there's a growing body of innovation in design and statistical advances. Everybody focuses on AI, but when we get to, for example, biomarkers, we have a putative biomarker. We have to be able to validate that biomarker, and that takes evidence-based medicine. And evidence-based medicine uses statistics, which also are just blooming in terms of new techniques. Here's an example of a new paradigm to try to get at what we're trying to talk about. So on the left, you see no drug placebo separation. Okay, so you'd conclude in this RCT, it didn't work. However, you do subgroup analyses and you see, this group didn't respond, this group did respond, what's different between them? So you can characterize them. People often say, stop there. And therefore, people with these characteristics are the only ones that should get the drug. That's actually not quite the proper logic that you need. What you need to do is you have to look at current placebo enrichment designs, is what it is. You have to measure each one of these groups against placebo to see if truly you've identified a group that should be using the medication. So who should conduct research? Well, the only thing about research teams that is changing is that it needs a wide variety of people. So not just the researchers, but the neuroimagers, for example, or the geneticists, but bioinformatics, it's going to include clinicians, et cetera. So that's just an expansion. But now we need to have persons with lived experience and clinicians on research teams. Why is that? One is because both of those groups have expertise that belongs in research. And the thing is, too, that it is very important that we do something to prevent the usual story, which is that it takes 7 to 14 years from a research result to get implemented into clinical care. That's just not acceptable anymore. So we have to integrate the research teams. What clinical transformations questions should be asked? Because really, think about it. What's our main goal? Our main goal is to have a clinical interaction in which precision is occurring. The research is important, it's critical, but that's not the end goal. The end goal is to have precision care. So how can we get care tailored? By what means will we know if it's working? Can it be maintained at any site? How do we know that precision population prevention is working? What do we need to ensure AI clinical algorithms that we build remain clinically relevant over time? And how will we know that precision mental health care or prevention is equitable, ethical, secure, and legal? And this is a lovely but disturbing slide that came from a study in 2021, a review. So it's based on data, but basically, if you start to the far right with discriminatory data being collected, okay? So you're already just collecting that unknowingly often, okay? Then you've got the design and deployment practices where you're applying, your AI model to then application increases the injustices. And then this produces real world patterns of health inequity and discrimination that are taken as fact. So, which experts should actively participate in precision mental health care? Okay, so you have patients and families, and we say, of course, they've got to be there. But what I want to point out is they're not just there anymore to be recipients. We need to empower them and use their expertise. They need to choose their treatment courses from menus that you provide. And in addition, they need to bring their expertise to the table. One of the ways that is currently doing this without even taking into account precision, the other factors in precision, are asking patients what they want. So an example of that is IPROMs, which is individualized patient-reported outcome measures. A good example is the goal-based outcome tool. You ask the kid, what is it that you want to get out of this treatment? And then you monitor that as well as their symptoms. Another example is social prescribing, which of course directly goes to the patient and says, what do you want? What do you think you need? Then of course, we have the clinicians who need to change because they need to understand all of this information. And because they need to understand all this information, researchers need to be part of the team. Now, how are they part of the team? Here are some examples of how other facilities around the world are coping with this. One is a team meeting model. So, they're getting, so an oncology program in Boston gets teams together. That is the researcher, the clinician and the family together, and they discuss treatment options, the research, et cetera, so that the researcher explains things, the clinician translates into what we're going to do, the patient gets to choose what they can tolerate and do. Another way is a research consultant. This is being done in Stanford in a precision psychiatry program, where they're sending research consultants out to the mental health centers and sitting down and saying, okay, we had you order this neuroimaging, for example. Now let us explain what it means and let us explain how it might help you choose the treatment. There's also EHR-based clinical data interpretation information, just popping it right into the EHR. And eventually there will be AI algorithms in the EHR combining those factors and saying to the clinician, here, this is what we suggest you think about for your patient, and here are the tools you need to understand it and the people to call if you don't. Okay, so how should we fund precision mental health care and research? It's not going to be funded by public health dollars in a very easy way. Instead, we have to shift to think entrepreneurially. So to think entrepreneurially, we have to think of the patient or the population. We have to think of where the problems are and what they need. We need to derive solutions with persons with lived experience, clinicians, or community workers. We need to embed solutions in viable business models. And we need to implement work within current federal or private grant systems, of course, but not expect that those usual strategies will be sufficient. We need to expand them by partnering with other organizations, like CHEO and SickKids partnered on this. Industry, nonprofit firms, venture capitalists, social enterprises. Now, next, I've got one more. What are the issues in interpretation and dissemination? Interpretation. AI studies already are fraught with overinterpretation, overgeneralization, and whoops, we forgot we had to validate what we found to put it into action. Marker studies, again, lack of validation, false assumptions about etiology. Do findings have clinical impact? If so, if not, what are the next steps to take to figure it out if it can be actionable? And PMH implementation studies, we have to have rigorous evaluation of implementation and effectiveness outcomes, and does it generalize to other sites? Dissemination, to whom and are they getting to the right places? Are the clinical implementation studies being evaluated and reported at all? Honestly, so far, we just are completing a scoping review. There aren't many of them out there, but honestly, they're not yet. And is scientific dissemination of all studies being conducted rigorously and in standardized ways? For example, with reporting guidelines like these. Here's the tripod AI guideline. So again, we're just finishing a scoping review. There were plenty of AI studies in there. We didn't see a single one, and this was created in 2015, just updated a couple of years ago to add AI. We didn't see a single one that had these guidelines that was reported. And the Be Precise guideline for reporting for precision medicine research. Again, we didn't find a single study that included this. Final piece that's very important to make precision medicine work is developing the workforce. So we need to use innovative educational models. How about training researchers, clinicians, and preventionists together for some of their work, their training? Teleeducation to expand reach, okay? Reaching out into the community, way far in Northern Ontario. Immerse learners in problem-solving transdisciplinary thinking, not interdisciplinary thinking, transdisciplinary thinking with other university departments, businesses, and community leaders. And some content examples, I won't read through all of them, but these are some of the things that need to be in the curricula for people that we're talking about for learners. Working with persons with lived experience, leadership in not only health professions, but in research and quality and safety, training them in innovation and entrepreneurship, how to affect public policy. Okay, so here is the ship that was guaranteed not to sink. What will sink the movement? Number one, failure to bridge that chasm, that 7 to 14-year-old duration, to jump that chasm from research to clinical transformation. Continuing to conduct research that doesn't adhere to evidence-based practice. For example, and this psychiatry is rife with this for a lot of reasons. Inadequate powering of samples, selection bias from convenience samples, recruitment focus on homogeneous white middle-class samples. This is we're not able to go forward if these are the practices that go on. Excluding the expertise of patients and caregivers. Overinterpretation of AI study results will just lead to chaos, and then eventually everybody will throw their hands up and say, oh, this is useless. ignoring the need for implementation and outcome evaluation, including economic costs. What we can't have is that precision child and youth mental health is only available to the wealthy or those in the tertiary care facilities. We just can't have that kind of an outcome. Overlooking population mental health, neglecting PMH effects on patient data, security, privacy, ethical, and legal systems, and continuing dependence on our usual lines of funding for these efforts. Okay, so we got a very wonderful donation, a first donation that we split with Sick Kids. And we, at CHEO, it was called the Precision Child and Youth Mental Health Initiative. And that was for 2 years. And we did a participatory logic model for that. And it was for our startup. So this is what we, we did a startup. The participatory logic model, we did a scoping review. And this is the case study, but participatory logic model included scientists, community members, legal, ethics, people with lived experience, clinicians, etc., multiple types of people. And this paper, I'm pleased to say, has had over 600 hits. We are very pleased that people are reading it. And this is just a quote from some of the data that we collected qualitatively, just so you know where we started. Right now, this was from one of our data scientists, we have no computer or research with adequate capacity to even allow the researchers and the computers to generate a profile for you. Now, what I want to tell you is we accomplished 80% of what we set out to do in this logic model. And one of the things that was the first thing that we did was really work with the CHEO, IS, informatics, people on our exec team you'll see later, to build high performance computing capacity to rectify this situation. So then we received another donation just recently for in 2024 to build what we have with Sick Kids, and we've built the Collaboratory, which is a research center at the RI, sharing ideas with lots of different stakeholders at all levels of the research and clinical care transformation endeavor. And what we have decided was to focus on 4 areas of change. And we're going to talk to you about each one of these areas that you see here in the graphic. And I'm now going to turn it over to my partner, Christina.
Thanks so much, Kathy. So just before I walk through some of the highlights of activities in the 4 pillars, I just wanted to touch on some of the operating principles that we have as we build and advance PCYMH. So firstly, as Kathy's really emphasized, the research and clinical care transformation are happening in parallel, not sequentially, just is really important for success, we believe. As is using knowledge from researchers, clinicians, and our persons with lived experience across the board in every project at our executive level. That we have a mindset we're thinking now, but also very much for the future, especially with respect to technology that's moving so quickly. So having a sort of a horizon scanning mindset, and also thinking beyond our hospital walls, of course, bringing precision care and prevention to the community, ideally. Next slide, Kathy. Thanks. Yeah, so we'll just start with our first pillar around translating research into real-life PCYMH care. I've got three things to touch on here. So it's really a priority for us to bridge this research to clinical practice for better outcomes, and to think about how can we be developing systems that's delivering this wide range of data to providers, ideally in a user-friendly way, with interpretation and ultimately influencing care. We are really excited with the momentum around measurement-based care, especially in mental health, across the mental health team. We've got some activity at the moment integrating, so both building patient-reported outcome measures, but not just the build piece, the thinking through to the how is the information, the data in Epic leveraged at the point of care, how are reports built for clinicians, administrators, sharing with patients, and not just thinking about the problems themselves, but as Kathy mentioned earlier, the concept of the individualized or perhaps goal-based outcomes as part of this process. So there's a lot of energy in this this project at the moment, and the second bullet here reflects non-PROMS data. We tend to focus a lot, of course, on the patient-reported outcome measures, but we have genetics, neurocognitive profiles, potentially information for devices, lots of types of data that ultimately we would love to see integrated into the EHR. More data will certainly lend itself to development of AI algorithms. In this space, we're excited to have submitted recently a manuscript summarizing our ED1 visit project. So this is a project using machine learning algorithms to predict emergency department revisits for children and youth presenting to the emergency department with mental health concerns. Ultimately, again, to influence care pathways, but at this point, just looking at the algorithm and AI opportunity itself. The second bullet here reflects some of the lessons learned through our early work, partnering with data scientists, clinicians, and helping understand what kind of conversations, how can we help make sure that the clinical real life problems at the front line are we know which ones are perhaps amenable to machine learning solutions. Not all will be or need to be, but how can we matchmake and bring together teams to collaborate in solving problems if the machine learning is an appropriate tool, and the enablers for that is another area of our activity. And lastly, in this section, we're interested in any ideas for demonstration projects. This is one we're particularly excited about because it builds on a study we, again, just published recently last year, more in the QI realm, a feasibility study demonstrating that, oh, thanks, Kathy. So this is using brief neuropsychological profiling, but the idea is to create a PCYMH treatment stream where we use a patient's own cognitive function profile to shape a personalized treatment plan that's strengths-based. So based on strengths, certainly weaknesses of the individual, but allowing the mental health providers to, this is an outpatient context, to track outcomes, tailoring the plan further as needed, but based around that cognitive function profile. We found certainly in our demonstration project really transformative results for some of the 39 families and patients that participated. Kathy, I'll just turn it back to you to touch on some of the research highlights.
Yes, and sorry I cut you off a little bit early. Okay, so I'm going to touch on the research. So we recently handed out 5 grants, discovery grants, and we feel like they all have a high potential for impact. We're also participating. One of our goals is to participate in multi-site PCYMH studies. For example, we are part of an OBI-funded CALM study, is what it's called, which when we talk about new methods for being able to do PCYMH studies, it's a master observational trial with deep and light phenotyping with several thousand kids presenting for mental health problems at the 6 sites. And then we'll be able to take kids out of that and do randomized controlled trials, as well as doing using AI to profile kids. And we're also working on developing an AI fairness tool for use in research. So here are the discovery grants that we awarded. They were in 4 clinical areas: autism spectrum disorder, mental health problems after concussion, eating disorders, and ADHD. And we're very happy that we're going to continue some of the great work that started in the people started in the PCYMH initiative. This slide is an overview. We have a student from Toronto working with Christina and me and Nicholas Mitsakakis. And this is an overview of what she's doing. What I'd like to point out to you is that there are 5 stages. And those 5 stages, conception, data collection, pre-processing, in and post-processing, and post-deployment, are all stages in the life cycle of a study. And at every single stage, there's the danger of, or you will find sometimes after the fact, bias. And this is all having to do with AI. And what she is doing is trying to work on with us a tool to help researchers, first of all, prevent bias. Second, identify it if it looks like the particular project's in danger of it. And third, remediate if it's already occurred. So the other thing that we're doing is we're building our complement of scientists who can do PCYMH work. And we're focusing right now on neuroimaging scientists and mental health digital technology scientists. So we're running a recruitment for the first, and we're about to start running a recruitment process for the second. We're also supporting whatever current work there is going on in CHEO in these domains. And now I'll turn it back to Christina.
Thank you. So our third pillar is to use technology to improve data available for PCYMH research. So we have been really pleased to be partnering with Jen Gillard and Jim King and the CHEO digital health side in implementing and evaluating a pilot of an AI scribe, the DAX Copilot. Some of you may be participants in this pilot, to improve the notes as a data source, and certainly there's an element of sort of supporting the workforce and hopefully reducing burden of administration. So a little more on that in a moment. Other examples, though, we're very interested in integrating any digital technologies that can be used to collect biological and psychological data that can be integrated. So lots of exploration work in this space. We could think wearables, we could think other tools to collect information. We're always interested in hearing about new and upcoming technologies that may be used in this regard. And certainly, we are happy to be working with Dr. Elamam, who's an expert in synthetic data, to support development of synthetic data systems for mental health research in particular. So yes, the DAX Copilot, we are now in month 4, post-go live. We have a nice, robust evaluation that includes, at this point, over 300 patients and families who've participated in an encounter that used the AI scribe. Feedback from them, the pilot participant interviews, and EPIC data as well. So we'll be compiling that in the coming months for use by CHEO and other decision makers to inform their next steps with respect to this type of technology. And we're interested on the PCYMH perspective, again, in sort of delving into what are the opportunities with this data to help inform PCYMH care, either from QI research, other opportunities. Finally, our fourth pillar is to advance the growth of PCYMH both at home and worldwide. Lots of activity on this front always. I just wanted to highlight, there's a lot with as Kathy was mentioning, around training the workforce, opportunities for transdisciplinary interactions. one opportunity we're particularly excited about involves a partnership, a joint fellowship concept between Sick Kids and CHEO. This is an exchange program that we're just launching, just developing, called the Clinician Scientist Training Exchange Program, or CSTEP. And the idea is to really combine clinical research activities and help trainees acquire expertise, early research output, early career research output, if possible. It can be pretty tailored to the interests and expertise of the clinician. And by clinician, this is open to not just physicians, but could be other specialists such as social workers, genetic counselors, psychologists in any of the focus areas you see listed here. So we're just embarking on this interesting collaboration with CHEO, between CHEO and Sick Kids. And if you're interested, you're certainly welcome to reach out around that. Building on the success of our PCYMH, our inaugural PCYMH conference last year here in Ottawa, we are planning for conference 2026. So next year, really excited about that. The first one brought over 175 participants, many international, to Ottawa, and really, I think, helped stimulate a lot of local relationships as well as international relationships. So that is definitely going to ramp up soon in terms of the planning for that. Next slide, Kathy. I think the next slide is a little closer to home. So it means a lot to us to co-design events with our youth and family partners, and just wanted to touch on this really, I think, a pretty unique collaborative event that we hosted just a few weeks ago in conjunction with Kim Courtney in the Family Engagement and Research Program. So what was really neat about this is it was at the art gallery in a studio. So what you see here in the pictures is researchers, clinicians, and the family partners for the discovery grants, the 5 that Kathy noted, getting together in person for the first time, all in a room, able to choose between, I think we had 4 different art workshops or tables for conversation, but I have to say the art workshops were far more popular. Really just to stimulate relationship building, idea sharing right at the outset of the research process. And we look forward to hosting more of these kinds of events and thinking creatively about how to deepen our relationships and opportunities for sort of impactful, meaningful engagement to drive research and outcomes that will matter for our youth and families. We are already at our thank you slide. This is really possible because of the energy and dedication of a lot of people, many of whom you see listed on the slide here. We are grateful for the executive sponsorship of Jason and Joanne Bazubetz. I understand Tammy will be coming on board soon, as we wish Joanne well in her retirement. And certainly, as you can see from a lot of the activity, it's very, informatics and IS focused. And so we really have been very grateful to develop relationships with both the hospital and CHEO research informatics teams. Oh, thanks, Tammy. We're looking forward to having you on board too. Certainly, we have a core team, mostly Ottawa-based, but also with some Toronto-based staff and our student, whose work Kathy reflected a few minutes ago. You can see some of us here on the slide. And Kathy, I think we're always interested in new opportunities for connection. So we have a hardworking core team. But we are very excited to issue an invitation for anybody. If you are excited about any of the concepts or the activities that you've seen reflected here today, this QR code takes you to a super short survey, just one question about tell us a little bit about who you are and how you'd like to collaborate, and we'll be in touch. We look really forward to growing this out internally. And I think we're just, not wanting to be remiss, as Jason mentioned at the outset, this is really made possible through philanthropy. It's a really nice example of the clinical research and philanthropic parts of Team CHEO coming together to do something really transformative and exciting. And so we want to make sure that we thank the Waverly House Foundation through the CHEO Foundation, and certainly our partnership with the CHEO that has made this possible.
Thanks so much, Christina and Kathy, for that presentation. It is amazing to see where PCYMH has come from its inception, and many of those things, you know, I've been aware of and had the privilege to participate in, but just seeing it all to come together. It's interesting that I was reflecting, you mentioned Joanne Bezubitz, who is retiring, and we wish her a happy and healthy retirement. Joanne, as I think many of you know, is a triathlete, and I just feel like I've been through a triathlon as you presented all of those various different components. And, you know, like a triathlon, you know, it only works if all of those different pieces, if you succeed in all those different activities and around education, around research, around clinical integration, family partnerships, leadership, operations, and all those components are going so strong under Kathy, your and Christina's leadership. I did have the opportunity to participate in the event at the Ottawa Art Gallery that Christina referenced, and I'll tell all of you, if you think research is hard, art is even harder. So there you go. We had close to 90 people on at the peak attendance, so it's great to see so much interest and enthusiasm for this project. And we have some time now for questions or comments. So please raise your hand or put a comment in the chat. And the Grand Rounds evaluation link has also been put to the chat. So put in the chat. So please complete that. So looking for hands. Tammy.
Hi, everyone. Amazing work. I've been cheering you on from the sidelines, but every time I hear you speak, I learn more about what you've been doing. So congratulations and thank you. I'm curious about the knowledge translation work into clinical practice. And so, you know, knowing that, you know, we have long wait lists, huge demand for mental health, what would be the accomplishment or the research finding that you can point to that you would say, yes, this we found and we now have in clinical practice and it's really making a difference?
I would say we're not there yet in terms of being able to say that. The closest thing that we can say is with the feasibility study of the cognitive function informed care. Now just feasibility, you can't really measure effectiveness, okay, although it's tempting. The feedback from the families was, some of them said this has been transformational. This has made a huge difference in my understanding of what to do as a parent and the kids. Some of them said, oh, you know, I got diagnosed smart. And then from the providers, they all said, can we start this now? So that's qualitative feedback about effectiveness. What we were heartened to find out was that it did not disrupt care. So the amount, actually, it was slightly, those kids, we offered it to everyone. So those kids who didn't take it, the care journey was no longer than the other ones. And in fact, it was a tiny bit shorter as a group, but it wasn't powered adequately to come to that conclusion, but it definitely didn't disrupt care. And the other thing was that the knowledge, some of them wanted it to go to the schools, which of course we were able to do with a consent form, no problem. But parents also felt like telling the schools would be very helpful and add extra bonus, which is why we're doing a big study to look at treatment dose, if you will, effect. So that's the closest we have. if you think of some of the other things that we're looking at, for example, so that's a core project, a core collaboratory project. Some of our discovery grant holders, Dr. Norris's work and his team's work from last time, because they had one, we're looking at biomarkers. And I know they found some interesting, and they've presented here, they found some interesting provocative signals, what might lead them to be able to maybe decide on treatments. So that's an example of something that is kind of on the path, but it's too soon to have a direct answer to your question.
Fair. Thanks, Kathy.
Mm-hmm. Other questions or comments?
Nancy.
Yeah, I was just trying to open my camera, but it won't open. That's okay. So I could just be here in the background. I wanted to say thank you for the presentation, Kathy. It was wonderful. It was inspiring. I mean, I've been working in the IPRO space for a long time, and I think your 7 to 14 years is a conservative estimate. It takes a long, long time to get things into practice. And I think that's a space where CHEO can lead. We're small enough to be nimble, to be able to integrate this work into practice. So I know you didn't have a direct answer. Oh, I can turn my video on maybe. But I think we will get there. We're not there yet. And I love that part of it. Not yet, but you will get there. So excited to see this. Thank you, Kathy and Christina.
Thank you.
Thanks, Nancy. While we're waiting for more hands, I wanted to ask about the upcoming conference. I know planning is just beginning. Again, it was extremely well attended, and we did have participants from as far away as Australia, which was really remarkable, and I think speaks to how this area is growing and the interest around precision child mental health. Have you thought about a particular theme or focus for the second conference? Obviously, the first conference was really more of a bringing the community, the global community together around precision mental health. But now as the field continues to mature a little bit, are there specific areas that you want to focus on? One that I was thinking about based on the presentation today was around sort of the relationship between AI, as you sort of alluded to, Kathy, sort of AI, and the need to ensure the oversight of that AI to make sure that it is a reliable tool. And obviously we have a number of AI projects, including those with mental health happening at CHEO. So I don't know if that's sort of a provocative topic that should be something that is looked at given the interest in AI. So wanted to hear your thoughts about that, and perhaps that opens up a little bit of a discussion. I know that Jeff and other Ivan and other AI people, Shifra, are on the call and may want to comment. So over to you guys.
Well, I can answer your question. Oh, because I wasn't sure. Are one of them commenting, which is great. That would be preferable.
Well, maybe first, Kathy, are you or Christina, do you think that's sort of a reasonable topic or something to touch on?
Yeah.
I mean, obviously we're still months ahead of the conference, but I know, planning takes a lot of time. To me, that seems like it would be a relevant topic to address.
I can speak.
Definitely. Go ahead.
Yeah, I was just going to say, I can absolutely. I think you put your finger on it, Jason. We're just going through some results. We had sent a survey to our past participants just to get a flavor of the kinds of topics that our next conference could touch on. And you're quite right. AI and technology was certainly one of, I would say, about 4 or 5 themes that was emerging. We're still kind of looking through and discussing. Obviously have a steering committee assembled to plan the conference, but the kinds of, just to give you an example, topics like responsible, trustworthy AI development, co-design with youth and families in the context of AI, clinical integration, and AI agents, pipelines, apps, interoperability, all of those kind of those themes were what we were hearing from our survey anyway. And then I'd certainly be very interested on you know, our CHEO team's take on that and how we could develop that into something something to really to pursue with the conference. I see
Thanks,
Ivan's
Christina.
camera on.
Yeah, Ivan's camera. Ivan's put his camera on. Go ahead, Ivan.
I was just on the phone, so I wasn't able to jump in. But yeah, I think one of the things that we really should focus on as well is really data and kind of the data availability that we have. A lot of these algorithms require a large amount of data. So how do we, you know, partner with other centers? How do we collaborate so that we're able to share data? And you know, the synthetic data project is kind of part of that, like unlocking our silos a little bit. And you know, new modalities of data such as wearables, where we would want to collect data that's, you know, potentially outside of the walls of CHEO, and how do we use that in some of these algorithms to improve care.
Thanks, Ivan. I don't know if anyone else from the AI group that's on wants to make any comments. Certainly think this is an area that that we can lead in, given the strength of our PCYMH team and our AI team.
Hi, Jason. Sorry, I was
Hi, Jeff.
getting a call at the same time, so just unfortunate timing.
No worries, no worries. Go ahead, Jeff. Jeff, do you want to introduce yourself, because not everyone may be familiar with you?
Sure. I'm Jeff Gilchrist. I'm the AI team manager and one of the AI scientists at the CHEO Research Institute. So our team, there's I guess a total of 4 of us now working on various projects. People can come to our team and we can help try to build AI models or other machine learning based solutions to help with either research or you know, clinical care on the hospital side as well. So we're starting to work on some exciting projects, and AI is becoming more and more important to analyze the large amounts of data we have and to try and see patterns that, you know, people can't easily see on their own. So lots of exciting opportunities. I think at the conference there's good opportunities to talk about various things. And I guess one of the things I wanted to point out is, like, with all of this, looking at like fairness and bias and other important topics, one of the things that I think we need to focus on at CHEO is making sure we're collecting the right data to be able to put people into those buckets and analyze to make sure the algorithms are fair. Because right now there's certain things that we aren't collecting. And I know I think there's a project that's starting to look at how, you know, we can start to look at those, collecting that kind of information. So again, on one hand, we need to make sure that things are being fair, and on the other hand, we don't necessarily have the information available to us to try and do some of those evaluations. So lots of these important topics we need to definitely keep a close eye on as we move forward and implement, you know, more things to use within our research and hospital space.
Thanks so much, Jeff. And Nicole, I see you put your camera on. I don't know if you wanted to comment.
I was just gonna, it's a separate issue, but I wanted to congratulate Kathy and Christina for such a wonderful presentation and truly inspiring work. One of the things I took away from the presentation, and I loved the examples of the hospitals where both researchers and clinicians are meeting with families, and really that cross-pollination between the two. I just love that idea, and it's inspired me, I think, to think about how we can be doing that at CHEO. And I think that is really something that our families would benefit from. So thank you for this great presentation.
Great. Thanks, Nicole. We are at time, so I think that's a great comment to end on. Thanks so much for everyone for joining. And again, as this is the last Grand Rounds presentation, pediatric Grand Round presentation of the season, I want to wish everyone a happy summer. Stay cool. Hope everyone will have some time, downtime with family and friends to enjoy the good weather. And we'll see you all in September. Take care.
Thanks, everybody.
Thanks so much.
Thanks, this was great.
Thanks.